Yeah, all set?
Yeah. Okay, so
Okay, just let me
it,
know when.
yeah, I already it's already broadcast.
Okay,
So we have
I can start.
uh wait do you want to share screen because
Yeah, yeah. Okay,
okay, yeah. So
good.
first I will introduce you first. Okay.
Okay.
Okay. So good morning, everyone. We are apologize because there is a technical issue, so it will delay for 15 minutes. So now we are going to start. Uh, Today, I'm with Dr. Thomas Spindler. He was graduated from Medical University in Rijeka, Croatia in 2009 and Dental University in Rijeka in 2011. After his studies, he moved back to his hometown, Ljubljana, Slovenia, to start his internship. Afterward, he spent 2 years as general surgery training and started his OMFS training in 2013. In 2015, he moved to Queen Elizabeth Hospital in Glasgow, United Kingdom. Dr. Spindler finished his training in 2017 and was appointed as an OMFS consultant in General Hospital Celje, Slovenia in 2018. His main focus now is surgical therapy of TMG and MRONJ. So here, Dr. Thomas Spindler, the stage is yours.
Okay. Thank you very much for your kind invitation and this very nice introduction. I apologize to everybody for the delay. We had a little bit of technical issues, as mentioned before. And thank you so much for taking out your 1 hour from this beautiful Sunday to attend this lecture. I will. So my name is Thomas. I work in Slovenia in a hospital in Celje as a maxillofacial consultant. So I try to, well, among other things we do maxillofacial surgery, I do focus on uh, TMJ issues with arthroplasty and surgical solutions for them. And then, of course, I found a special challenge in treatment of bisphosphonate necrosis, which is a little bit controversial issue. And I picked this lecture because I think there's not often mentioned in your curriculum. And I think because the population is getting older and bisphosphonate use is getting more and more common, so you guys will be seeing more and more of these patients. So I think it's nice that we go through some cases and explain uh, what can be the tricks that you can encounter in your everyday practice and when to refer to a specialist care. So let's start. So my goals for today for you would be, if you understand what is medical related osteonecrosis of the jaws, which is MRONJ. If you can define this, that's fine. Then who are the patients at risk, how to pick them out from your general population, the people that come and see you at clinics, which diagnostics you can do at your offices and what diagnostics we do at hospitals, and then what are the two main streams of therapy we offer, and then of course what you guys can do in your clinics and when to refer, because often I see that dentists are sometimes confused a little bit when to extract, when not to extract, when to be afraid of these patients, and so on, and then often I see that people extract and have a little bit of bisphosphonate necrosis and then they feel guilty that they caused this. So if we can clarify what is actually the cause of this, that basically you dentists are not behind this, and not to be afraid of this patient, then I think it's my goal will be achieved. So what are we talking about? MRONJ, as we said, is medication-related osteonecrosis of the jaw, and it's a side effect of this anti-resorptive treatment in cancer and osteoporosis patients. Was first described about 17 years ago by Marx, and since then there has been extensive research, extensive patient reports, A lot of articles have been written about it, but up to now we still have lack of exact knowledge what causes this, and how to exactly treat it. So a lot of its aspects remain controversial, and that's the fun of it. That's the fun of working with those patients, because you see there's old patients, they have exposed bone, they cannot use their dentures, they don't have teeth, they're unable to eat. The bone is dying in their mouth, and actually helping them is quite rewarding. Although it's quite difficult, as you would see, to get final treatment and to get a final good result. So the starts, of course, it's all the definitions. All your lectures and all your books will always start with the definitions of it. So it's probably best if we define the problem we are dealing with. So there's always 3 steps in this definition. And so first is the patient has treatment with anti-resorptive or anti-angiogenic agents. The second one, that probably that's the most important one, that there's an exposed bone or bone that can be brought through a fistula, or sometimes even an unexplained bone pain that has persisted more than 8 weeks or 2 months. And sometimes everything just looks normal inside the mouth. The patient is saying, but there's pain here, doctor, there's a lot of pain here, and you have no idea what's going on. So if you go through thorough anamnesis, patient's history, then they will remember, oh yeah, there is something I'm taking for my bone every 6 months, but that's not important. But to you, it's very important. And then, of course, there's no history of radiation therapy in the head and neck region. There's no cancer and anything. So basically, you take this out of the picture. But then those were all the definitions. How does it look in real practice? Then that's the thing that's most important for you guys. So then it's pain, swelling, fistula, abscess, pus, and mostly you will just see exposed bone that will start after tooth removal, unstable prosthodontics, or just because the body doesn't like it. How does it look? There you go. There's the first one. I hope you can see it. It's an exposed bone in the region of 4.1 to 4.4. And here's just a small sinus, but underneath there's a giant necrosis. Then it's a bit of more exposed region in the molar region. And as a patient of mine, of course, the upper tuberosity is completely died off from bisphosphonate necrosis. The risk factors, at first it was thought that the dental extractions are the cause of it, but then again, in truth, the underlying condition the patient is getting bisphosphonates for is actually the risk factor. Everything else you will see, are the extractions, are dental infections, it's periodontal ligament that is infected, then unstable prosthodontics, sometimes it's just smoking, diabetes, immunocompromised patients, and then in some patients just random factors, because your life as a dentist is not difficult enough. You have to have this random unexplained factor that causes bisphosphonate necrosis, and then when the patient asks you why did I get this, you have no answer for them. So once again, I would like to point out, when you start treating your patients, or even if you want to perform an extraction, always ask them if they take bone medications, especially if they're old patients. As I said, if they get an injection every 6 months, they don't remember it, and they just forget it. And sometimes you just ask them for any medical history, any older letters they have from endocrinologist or from GP, and then sometimes you will just find it inside there that's written in Xgiva or something else, and so this will make everything a bit more clear. So always ask them before you start making an extraction or surgical procedures. Whose fault it is? I hope I'm not too old to be promoting this movie. It's a very nice movie. It's a great movie from my youth, but now I just feel quite old to have to explain it to you guys. So it's the usual suspect. And let's see who fault it is. It's anti-resorptive drugs. I've just listed the list of most common used drugs. that are used for our patients. Now, in every country, their name will be different. I listed the most common ones. So it's Bonviva, Prolia, Xgeva, Zomita, Eclasta, Fosamax, and Fosavans. The thing is that usually if they end with onate, you should be quite careful, and this should ring a bell, and you just Google it. It's nothing wrong if you see a drug you don't know, and then you just Google it a little bit and think about it. How do they work? What are those drugs? So the theory is that the bone is always remodeled. There's always harmony in life, like yin and yang. There's always something is building and something is removing the old bone. So this is the balance between osteoclasts and osteoblasts. And then the osteoclasts are cleaning up the old bone. So everything that is supposed to be clean, like an infection or old bone cells, the osteoclast will just clean it, and then the osteoblast will just make some new bone. This is the way of life. But when you get older, when you get osteoporosis, then your bone is a bit more porous. So what you want to do is you want to shift this balance towards the osteoblast. So basically the osteoclast will leave the bone alone, and the osteoblast will build new blocks inside the bone and make it a little bit more dense. If you talk about cancer patients, they are at risk of metastasis inside the bones. And what you want to do is you want to make the bone a bit more dense, so the metastasis cannot progress further. And this is again what you want to do, is that remove the osteoclast out of the equation and allow the osteoblast to build a very firm wall around the metastasis, and they'll trap it inside the bone. So anti-resorptive drugs do inhibit the osteoclast and so make it a little bit more denser. That's very nice. That's amazing. And for the patient, this is really good medicine. But on the other hand, when you talk about the mouth, it's a bit more tricky. So if you just put in an example, if you extract a tooth, it's so difficult to extract the tooth with total atraumatic measure. So you extract it, and there's always going to be a little bit of bone that's going to crack or chip away, or there's always going to be a little bit of injury. And this injury, usually it heals a little bit. But if you think on microscopic level, then one or two cells of the bone will not heal. It will die off. And this is going to start a little bit of necrosis. And if you have an osteoclast that is blocked, so basically your vacuum cleaner for the bone is blocked, and you cannot clean, the necrotic material inside your bone. And therefore, this starts this vicious cycle of an osteonecrosis. Osteoblasts will try to build everything around it, but you have a small infection that is not going to go away. And this infection then just slowly spirals out of control. And this is, I think, how you get most of the bisphosphonate necrosis. This is very simplified theory. There's so many theories, and none of them are proven exactly right. But the thing is that you also have idea that there's some soft tissue toxicity. They block the vascular supply. You cannot explain why then you have this random bisphosphonate necrosis when you have no stimulus to it. But I think most of it, you see it with some decubitus from prosthodontics or extractions. And I think this is kind of most common mechanisms how you get it. Bisphosphonates usually have an affinity to hydroxyapatite, and they stay in both for 10 years and even more. So therefore, if you have a patient that has taken bisphosphonates for 5 years ago, you always treat it as if the treatment is still active. While denosumab, it's a monoclonal antibody that functions as it binds as a rankle receptor to osteoclasts, and then it's only active for 6 months. Therefore, you can, after 6 months of treatment, you can actually perform everything more or less as if there's no treatment involved. So always, if you have a denosumab in patient's history, like Xgeva, then perform extractions just before the next injection, because the concentration in the blood is the lowest at the time. And often I see the patients are getting denosumab, and 2 months after the injection, dentists do an extraction, and then you have bisphosphonate necrosis. So always take care of this one. Incidence, well, incidence of this disease is quite low. It's very low, and so for example, in cancer patients, they get high potency bisphosphonates. There's only about 1% of patients that will go on oral procedures will get this disease. You will find articles that will say up to 24%, but they have small numbers. So usually when you sum everything up, it's about 1%. Osteoporosis, I think it's only about 0.1 to 0.2%. So you see that if patients are getting low potency by bisphosphonates, the chances to get MRONJ is quite low. And if you don't have bisphosphonates, so if you get any other, then the chances of getting this disease is very, very low. So if you think about it, you don't have to be afraid of those patients. You won't. The chances that you will cause this disease is very low. There still have to be warned that bisphosphonate necrosis can happen, and you have to explain to them that it's tricky and you cannot define how far it will progress. But I think if you extract as atraumatic as you can, and then suture everything, and you smooth all the rough edges, you can basically have no problems. And I think I can speak from the experience that I get a lot of patients, either cancer patients and osteoporosis patients, and with nice and meticulous wound care, basically there's almost no returns with necrosis. So really wound care afterwards is very important. And then of course there's always a little bit of staging. Not all diseases are the same. So I think it's quite important that you understand what stages of the disease are, because it's quite important as well. This will influence the treatment afterwards. So stage 0 is there's no clinical exposed bone. There's just some pain, dull throbbing pain inside the bone. There's no fistula or anything. Sometimes there's an implant as well, and behind it there's pain. You think it's periimplantitis. You treat that, but the pain still remains. Sometimes the teeth are just fine, and just this bone pain, and then if you start speaking to the patient to see that he's having bisphosphonates, this is stage 0. It doesn't mean the stage will progress. Most of the times they just stay at the same stage, but sometimes then it progresses to exposed bone. Sometimes you just have a fistula you have to look for, but an asymptomatic bone with no infection, which is exposed, basically causes no problems to the patient. So the complaints will be that the patient just has exposed bone, and they will say, look, this is something in my mouth. But as long as there's no symptoms, patients can live with it, and they won't be coming back with any complaints or anything. So you can just leave it be. Then the problem becomes when they're starting to flare up. When they have signs of infection, pus, then you need to do a little bit of treatment. And then when the bone, exposed bone starts to progress, so you get pathological fractures, extends beyond the alveolar bone to other tissues like soft tissues, other teeth, then sometimes even goes to the maxillary sinus. You get a AO communication. This is stage 3. And this is something you really need to refer to a surgeon. And this is something that really needs to be taken care of, because it causes quite a lot of pain and problems to the patients that are not easily solved. Diagnostics. What is the things you can do in your clinics? I think the most important one is the OPT. It's a standard practice you do actually for your patients, and I think it's quite nice. You can see everything you need to know. It's the imaging of choice for lower stages, and it shows quite nice. Here on the X-ray, you see in the lower jaw, there's from 3.1 to about 4.3. There's a defect of bone, which is bisphosphonate necrosis, and this basically gives you a bit of idea how big the defect is and what are you talking about. Then if you're able to do a CT scan, fine. This is probably even better imaging, because it shows you in 3D the defect, which tissues are involved, and what you need to do. This is a CT scan of a patient of mine that he was a cancer patient, a renal cancer patient with Xgiva. A dentist had removed the upper molar, after which he got this enormous osteonecrosis. As you can see, the sinus is also involved. And on the other side, he has a cyst that nobody has seen for many years that we also had to remove. And it turned out it was a keratocyst. So it's quite nice to have a patient with already bisphosphonate necrosis and keratocyst that needs to be removed. But in the end, you'll see in the case reports, it all ended up nice. Then, of course, you have more high-tech diagnostics, which is MRI, which is amazing as well. It will also show you the soft tissue involvement. It's also very good, but if you think about it, the availability of MRI is quite difficult. The waiting lists are long. How to obtain MRI, it also takes about half an hour. The costs are enormous, and it won't give you that much more information in regards to CT scan. So I think if you have to do something, a CT scan is better and more cost effective. And then, of course, the PET scan, it will detect any change in bone metabolism. If you have an infection, of course, it will show, it will be a shining. It will show you that there's something going on, but it won't tell you the exact defects and the exact tissues involved. The costs are enormous. And again, it's not something you can do in a week's time as you can do in a CT scan. It's something that you need to wait for a couple of months. And by that time, the disease will progress. So the surgery will be more extensive. There's another thing that is developing is fluorescence. So how does this work? Is you give the patient doxycycline 10 days before surgery, and then you need a special Weld scope that will show you like kind of a greenish light of the vital bone. So you dissect everything else. It's nice, but if you work in a smaller hospital, you just can't afford this. So this is something that is really reserved for the higher centers. So I'm trying to show you how you can do it in a smaller scale hospitals. And then the rule of thumb, if you do a surgery, there's always you try to remove bone until you get a bleeding bone. But then if you do a fluorescent bone, sometimes you see there's a big difference. So the necrotic bone can go deeper. And I think fluorescent is quite nice, but I hadn't had a chance to use it yet. And then treatment, how to treat it. Stage 0, as I said, observe, symptomatic therapy, painkillers. There's not much you can do, and this is what you need to explain to patients. I think also it's quite nice if you're able to explain to your patients what are the real expectations of the disease. So I think it's pointless to try and sell them, this is going to be fine, don't worry, I'm just going to rinse this and everything's going to heal up and it's going to be nice. I think it's much nicer if you explain to them the real expectations, that your goal is to get them pain-free and symptom-free, and if there's going to be a little bit of exposed bones, so be it, but as long as their quality of life is okay, then you're quite happy with it. And then they accept this much nicer than if you explain to them, oh, everything's going to be nice, don't worry, we're going to get you implants in this one, and then 6 months down the line, they still have problems, and then they're just angry and unhappy. So I think sometimes it's an unpleasant debate you have to have with them, but it's better to explain to them it's difficult to treat them fully. Then you get to stage 1, when you have a little bit of exposed bone. What you can do is local hygiene. Sometimes you can take a drill and then just smoothen the soft edges a little bit, trim it a little bit so it doesn't irritate the tongue. Chlorhexidine rinses, good hygiene, and that's more or less everything you can do. In this stage, more often than not, sequestrum will fall out at some point, and then the wound will usually heal. At stage 2, if we get back, then stage 2 is exposed bone with a local infection. And here you just give them antibiotics at flare-ups. Some articles or in some clinics, they give them antibiotics for a year or two and just treat everything. In my point, I don't see why antibiotic for a year for something for necrotic bone will do any good, because the bone is dying off and antibiotic will not sort this up. And you're not treating an infection of a bone, you're trying to treat a necrotic bone with an antibiotic, which has no sense in my point of view. So only when you have a pus or flare-ups, then you give them antibiotics, but in the meanwhile, just chlorhexidine and local hygiene supportive. And then in stage 2, you kind of start thinking about surgical treatments. And then in stage 3, when you have involvement of larger parts of the bone and a lot of problems from patient, then yeah, you go into surgery and you do a little bit of removal of the bone. Success, how to get successful with all those patients, we would all love to have patients with fully healed mucosas. There's no necrosis on the bone 1 year after therapy, and then you can start thinking about prosthodontics, dental implants, everything. But in practice, I'm really happy if I reduce the exposed bone down to a small sinus, and the patient has no issues, no pain, and when they come up for every 6 months for the review and they say, oh, I'm fine, I don't have any pain, and I'm quite happy with this one. And usually they are as well. They get used to not having teeth, and I think it's quite nice for them. I was mentioning there's 2 pathways of therapy. So one is the conservative, wait and see, and then you basically just see patient every 2 months and wait for something to happen, or you can be a bit radical and go into surgical treatment. Surgical treatment is, I think, still a little bit controversial, but in last years it has proven to be a bit quite successful, and I think it's a faster way to get to the end result, so to a patient that doesn't have any real issues. So I said conservative, you have an exposed bone, the patient has no complaints, they have steroids, for example, you cannot put them into general anesthetic, they're just not the patient you are confident enough that if you do a surgery, everything will be fine. So steroids, for example, the soft tissues more or less will heal slowly. You have a lot of wound breakdown, so there's always a little bit of problems. In my point of view, what I see with colleagues that treat bisphosphonate necrosis with conservative treatment, how it looks like is, so there's a lot of follow-up. So you see patients every 6 weeks to every 3 months. They're always taking antibiotics, so they have stomach problems, gastrointestinal problems, they're fed up. So there's a lot of, so your clinic is always full with these patients. They always have complaints, and it's quite normal that they have a lot of problems. There's pus, there's fever, there's discomfort. If when you have this big, large necrotic bone, there's even people around them are they don't want to sit next to them. That's the usual complaint I have. And it's not pleasant to have this in your mouth. And also they cannot get new dentures, and so it's a lot of waiting game with a lot of discomfort for the patient. I think in lower stages that's okay if they don't have complaints, but in higher stages, I think surgical treatment is really the way to go. Surgery, what you do basically is you remove the sequestrum. The bone is kind of covered with the biofilm, and the sequestrum will form even if you wait long enough with antibiotics, or if you just wait long enough. The sequestrum will form, it's going to fall out. And then after that, in most cases, the mucosa will heal over it, and you're going to have a patient that is healed. But this can last for about year and a half. And with surgery, what you do is you just speed up this process. So what you do is basically remove the bone, you get down to the bleeding bone, and therefore you remove the sequestrum that's gonna form in a year's time. And then, of course, people that are not so much for surgical treatment will object that, okay, you take a little bit more bone that's needed. But I think it doesn't matter that much. You will maybe take a couple of millimeters of more bone, but you'll get a bleeding bone, and the patient will get the result quite faster. And you won't, even if there's sequestrum is going to form, this is not a nice retention for prosthodontics. You will always have to do something else for them. So if you remove it surgically, you basically won't do much more harm, but you will get to a happy patient with a healed mucosa much faster. And I think this quite improves the patient's quality of life. So the principles, yeah, you have the minimal invasive, so basically just debridement and sequestrum removal. You can do this in your clinic as well. You could just take a burr and remove it a little bit, so just get everything nice and smooth. And then if you see that the bone is mobile, you can just grab it with a vascular clamp and just remove it. And then sometimes you just have to do a larger resection and cover it with buccal fat pads and use free flaps, which I will show later on. But the thing is that the goal is that you get to the viable bleeding bone, something that is nice and clean and then looks healthy, and this will usually heal. And then this defect needs to be covered with a well vascularized tissue. You don't leave it to granulate, but you just leave it, you just close it meticulously without any tensure. And I think layered closure is the thing you want to go for. And this is going to sort out quite a lot of problems. And also be radical. If you do a little bit of surgical principles, remove all the teeth that are affected, everything that is dubious, everything that is already quite close to the necrosis. I think it's already affected, so be radical in this one and just remove the teeth that doesn't look well to you. Because what the conservative approach in surgical will mean that you do a bit of surgical, and the wound breaks down, and then you have to do another surgery a couple of weeks down the line, and another surgery, and nobody likes this. And then if you get a scar tissue, this is not gonna heal nicely. So I think if you do surgery once and be quite radical about it, it should be okay. And the tip of the iceberg principle, I'll show in the later pictures, is basically the necrosis is always much bigger than you think. So even if it looks a small sinus, when you open everything up, the necrosis is going to be bigger. And if the maxillar sinus is exposed, you always have to close it with the buccal fat pad, not just a soft tissue, but a fat pad, so it gives you a little bit more protection from saliva. Tip of the iceberg. So for example, here you can see a patient that has a small fistula. On the OPT, you can see what's the big difference. So basically, even the 4.3 is involved, even the 4.2 is involved here, and the necrosis goes back to the 4.5, almost to the 4.6. But if you look just intraorally, you would say, oh, this is just something very small. And then when you open everything up, this is the necrosis you will see inside. So the tip of the iceberg is don't underestimate the disease. It's always bigger than you think. So what's the role of the PRF? PRF is platelet-rich factor. It's something that is getting more and more traction in the treatment, in the surgical treatment of this disease. I think of it as an extra layer of protection. So you take this necrotic bone, you drill it down to the bleeding and nice and healthy bone, and then you would have to put a bit of soft tissue over it. But if you put the PRF in between, even if you have a little bit of adhesions, the PRF is gonna protect your bone of saliva, and it's gonna promote the soft healing above it. Now, does it improve bone healing? That's a little bit questionable. There's no real science behind that, so I'm not going to promote that it does promote bone healing. Although in my experience, it's quite nice as well. It does help. It does make a little bit of difference. So how do I do it? So if I do a little bit of, if I have to do extraction, I don't use antibiotics unless the medical history demands it. So if they have a cardiac issue, then yes. If they have a kidney disease, yes. But in general, I don't use antibiotics. I do a gentle as atraumatic extraction as possible. If there's a molar, I separate the roots and then just extract all of them, remove all the sharp edges. If there's an osteoporosis patient, just primary suture and always heals well. If it's a cancer patient, then I raise a flap and then undermine it, nice, cut the periosteum, and then tension-free closure. And I always review it in 8 weeks. So if you guys are going to do it, always have a review in 8 weeks. If the wound has not healed, always think about, okay, this is probably bisphosphonate necrosis. Am I okay to treat this on my own, or just refer it forward? Don't extend this treatment for longer than it needs to be. So review in 2 months. If it's not healed, just refer further. Okay, so this was a little bit of theory behind it, and I think now it's okay if we go to a little bit of surgical treatment. This is, I think, when I started working, this is one of my first patients that came in with an older patient, as we said, with cancer of kidney, metastasis to the bone, exgiva. Tooth was extracted 1/8, and then this giant necrosis happened. We put him into general aesthetics. We removed more or less all the necrotic bone, but I was maybe not radical enough. So he ended up with the dehiscence. As you can see here, this was after surgery, and I removed quite a lot of bone already. And after a year, I think he came back. He said, "Oh, there's something wobbling in my mouth." So we removed this giant sequestrum. But underneath, the bone was healed already. Everything was healed quite nice. So I referred him to my colleagues in prosthodontics, and he ended up with a nice prosthodontics. So he's quite happy with it. But the difference is that he had to wait for another year to have this problem sorted out. So in the case 2, there's this lady that had so lower 4/4 removed, and after that she developed quite a giant lesion of bisphosphonate necrosis and was referred to our clinics. And as I said, the 4/3 and the 4/2 actually are all involved. So we put her in the general anesthetic, and we opened everything up, removed all this granulative necrotic bone. As you can see, the difference, the bone that has removed is quite substantive, but it's nice and nice and bleeding, so you can see it's a viable bone. We closed it in meticulous, so we closed it with tension-free, and this is the result. I think it's almost a year after surgery, and there's no exposed bone. So basically, we were able to sort the bisphosphonate necrosis in a matter of 1 month. So the next patient, it's the same. Also had a canine removed. It's also an older patient with a cancer patient, I think, higher potency bisphosphonates, also referred to us due to exposed bone. So we also removed this sequestrum from the bone, which is, I think, the most important part. And then we removed all the necrotic bone down to the bleeding bone, and we used the PRF. This was later on. I started using PRF, so I just put it inside and then closed everything primarily. And this is the end result, which is also no problems, no issues. Everything was healed nicely, and a year after the procedure, she's still fine. No issues there. Case 4, this is a younger patient. I think he has multiple myeloma. He's having an exgiva with metastasis to the bone. And then he came to our clinic for exposed bone above his 1/4 and 1/5. So we had to do a bit of more extensive approach. We performed a CT scan where you can see a bit of necrotic bone, and the AO communication is already formed. The sinus is also involved already with the chronic infection. So we had to do an extensive resection, and we planned to cover everything up with the buccal fat pad. So this is probably one of the first times I used piezo for removal, because I thought it's going to be nicer. The bone is going to be a bit cooler. So if I use a rotatory bore, it's going to warm up the bone a bit more. So we used the piezo, and I marked up everything where I wanted to remove the bone. This is where you see there's a bit of there's a sinus, so the bluish thing underneath the bone, and there's the sinus that was exposed, removed a little bit, and we drained a little bit of pus. Here we mobilized the fat pad, and then we covered everything with the PRF, and then closed everything primarily with no tension. And I think a couple of months after the procedure, the patient is fine. There's no exposed bone, there's no sinuses, there's nothing. So he's completely fine at the moment. So this is the things you can do even under local anesthetic. It's not pleasant, but you can do everything under local anesthetic. But then jaw resections are when you want to do a little bit more, when the necrotic bone is more extensive. And so we have marginal mandibulectomy. So for example, here on the left-hand side, you can see there's a bit of necrotic bone that you can actually remove under local anesthetic. Here we go. And then segmental mandibulectomy. Here, if you can see, there's a giant necrotic bone from left angulus almost to the right angulus, and this is something you cannot do under local anesthetic. And this is something you need to have a general anesthetic and somebody that knows how to use free flaps and do a segmental mandibulectomy. So this is the area you would need to resect. And then maxillectomy. Here, as you can see, there's an enormous part of maxilla that has died off, and you basically have to remove almost half of the maxilla to perform this surgery and to get everything nice and viable and to close it with soft tissues. Jaw reconstructions, of course, you always have to have patients that are well in general condition, that can go under a general anesthetic, and then various flaps, fibular, scapular, DCIA. I think fibular is kind of the most used. And you always have to do an adequate resection. You can pre-plan it with 3D prints before, so everything is faster. And the bone in the for example, fibula is not so much affected by bisphosphonates, so the healing usually is quite nicer, and the patients have a nicer result. So that's the case for the general anesthetic. This was given to me by colleagues of mine from University Clinical Center in Ljubljana. So the patient was an older patient with cancer and high potency bisphosphonates, came in with what seemed to be as odontogenic infection. But when they performed OPT, they've seen there's a giant area of necrotic bone in the lower mandible that had to be resected. There's a CT scan. Okay, this is sorry. Sorry, this is my 4-year-old that wants to see what my so she was they performed a resection of the mandible in the lower jaw, resected everything from the left angulus to the right body. This is the area of the lower jaw that was resected. And I'm very sorry. I'm really sorry. So they performed the free flap with the fibula that was preformed. I'm sorry. I'm sorry for this one. Technical problems, I guess. So the plate was pre-bent. The plate was pre-bent, and the fibula was cut already on the pedicle, and then just put inside the lower the plate and fixed inside the mouth. The patient achieved quite nice osteointegration, and later on they actually managed to put 4 implants and removable prosthodontics inside her mouth. So I think that's quite a nice result for a very, very complex case. And then another case, which is still, it puzzles me, and I think it's going to show how odd this disease is. So this was a patient that came to me as well. His dentist extracted a lower 4-4. Then the patient developed bisphosphonate necrosis of the lower jaw, and then the dentist, for some reason, thought it's the best to just do a new removable prosthodontics and wait for everything to heal underneath the prosthodontics. I don't understand the logic behind it, but then the patient, of course, developed an enormous area of necrotic bone, and we resected it under general anesthetic. We removed quite a lot of bone, and then everything fell apart, and he ended up with a very big area of exposed bone. I think it was from 3.2 down to 4.4. So this was the area of exposed bone in his mouth. He didn't have any problems, no pus, anything, just exposed bone. And then on follow-ups, I could see that there is soft tissue slowly going inside and closing the defect. And after a year's time, everything just closed up. So it was just all nice and healed. And then I just said, and then the guy started asking me, look, I'm not on Angisgiva for a year now. Can you get me some implants? And I want to have some teeth. So I did an X-ray and a CT scan, and this is what he has in his mouth. So it's a pathological fracture of his lower jaw, but it's all nice, completely healed. It's not moving. It doesn't cause him any problems. The mucosa is healed over it. So I have no explanation why the patient with the jaw like this is walking around with no pain, eating with no complaints and everything. So I just wanted to show you the disease is odd, and it's quite difficult to explain and predict the results. So antibiotics, go back to a little bit of theory again. Antibiotics, yes or no? Some people say yes, other people say no. It's a bit of a controversial topic, and even if you go and listen to all the big names that lecture MRONJ, there's no consensus about it. From my point of view, I don't use antibiotics because I feel that antibiotics should be used to treat an active infection, not to prevent one. So I think if you extract a tooth as atraumatic as possible and then take care of the wound nice, you won't need any antibiotics. And then the other thing is, also we'll read about drug holidays. Some articles will promote it heavily, and then some others will say, oh, it's completely a waste of time. And again, there's not enough evidence to confirm any benefit to it. So drug holiday, yes or no, depends. I think you should discuss this with the doctor that prescribed, that started the bisphosphonates. What I think is quite important is that just to perform any surgical procedure before the next application of the bisphosphonates or Angisgiva or denosumab. That's, I think, is the key area. Not the drug holiday, but just to do it when the concentration is very low. And then in low risk bisphosphonates, the risk is so small, so drug holiday don't bring you any benefit. And then in high risk patients, for example, if they have prostate cancer with metastasis or breast cancer with metastasis, then you always have to think about what are we trying to treat here. So are we trying to treat the patient, or are we trying to treat the exposed bone? Because if you stop the bisphosphonates to try and get this bone to heal, okay, you might do it, but you might not even do that. But if you remove the bisphosphonates, you're actually removing the one thing that is stopping the metastasis from progressing. So basically, you are endangering the patient for a treatment that might prove to be successful, but might not. So I think stopping the bisphosphonates for cancer patient it's not productive, and I think it's just endangering patients. And basically, what you want from them is to live. And if you have the bisphosphonates necrosis in the mouth and be alive, you know, it's a small price to pay than not to have bisphosphonate necrosis and end up in terminal outcome. Dental implants for bisphosphonate patients. Again, if you look at the literature, it will always say, look, it's compared to the normal population. So the normal success is about 98%, but with dental implants, about 90 to 95%. So I think it's not something you need to rule out immediately. I heard a very nice lecture in Denmark that said it's not so much of the osteointegration, but the peri-implantitis is something that is quite difficult to control in bisphosphonates, and it makes quite a lot of sense. And then again, look, if you decide and the patient wants to have dental implants and has bisphosphonates, then if you feel comfortable enough, I think you can go and do it. The literature is behind you. And there's a Danish study at the moment, I don't think it's been published yet, for high potent bisphosphonates for cancer patients. And as far as I'm aware of, they have quite promising results. So it's not a complete contraindication as well. But I have to wait for them to publish it. So what you can do, maybe a little bit of cookbook approach, what you guys can do in your clinics. So carry out all your routine dental treatment. If an extraction or something on the bone is required, discuss this with the patient. See if they want to have this extracted, or sometimes you can just, retain a root, do an endo treatment of a root and clean it nice and just leave it there. And, you don't have to expose the patient to some risks. Sometimes even you have a bit of a impacted molar, there's something out, there's a little bit of crown sticking out, but there's no problem. So why would you want to expose this patient to a surgical removal and end up with bisphosphonates if they've lived with this molar for 70, 75, 80 years? So, antibiotics and antiseptic prophylaxis, said it's not needed if you want to do any perio or any extractions, unless they have a reason for that. And if they have any concern, you need to be able to be available to them, and always review them 8 weeks after surgery. High risk patients, I think that's best to be referred. You can also do your dental treatment, all the perio treatments as well, but try to retain the roots as much as possible. And then if you want to have it removed, I think it's maybe best to send it to a consultant or a surgeon. I think one thing that's quite important is that you explain to the patients that are getting older that before they get osteoporosis treatment like bisphosphonates, that they come to see you and you do a radical treatment of their mouth. So extract everything that is not going to be in the mouth for about 5 years, do a nice oral hygiene, and just then keep them on the radar for as long as you retain them. So those patients are kind of the VIPs of your clinic. What you can do, this is a small spreadsheet. So I think what dentists can do, before, so you can see the patients before they start anti-resorptive treatment, perform everything, clean their mouth, and then if they have a low dose osteoporosis for less than 4 years, basically you can do all the procedures inside the mouth, even extractions. You don't have to refer them to the surgeons. The waiting lines are long and the patients are going to be unhappy. So basically those patients you can treat on your own. If you have a patient on cancer that are high risk, or osteoporosis that has more than 4 years of treatment, then maybe you can refer to them to a consultant. And if you have a suspicion of bisphosphonate necrosis, and the patient has any problems, then basically you just refer them to a consultant. So in the end, well, always before you start extracting, assess whether the patient is taking anti-resorptive drugs, and then why are they taking it, and how long are they taking it, and what would be the risk for that. Always ask for glucocorticoids, for steroids as well. Those are quite difficult. Even if they have steroids and you do an extraction, there's always a bit of complication. But if they're in combination with anti-resorptive, they are complicated patients, and the risk for bisphosphonates becomes a bit higher. After 5 years, the patient becomes high risk, so try to refer them to a consultant. If bisphosphonates have been taken in the past, just treat it that the patient has active therapy now. Prioritize them if they start with any bisphosphonates therapy, just treat them before that, do radical extractions and everything. Antibiotics not necessary, and extract before the next dose. So if they get denosumab every 6 months, just wait for another 4 or 5 months and then extract them. Don't get yourself in trouble. And then before starting any treatment, just remove everything that doesn't look promising, or it's not going to be in the patient's mouth for the next 5 years. So just clean everything up and have good foundation before they start bisphosphonates. Okay. That's it for me.
Okay, thank you very much, Dr. Spindler, for very precious explanation. So we are going to have some questions, Q&A
Yeah.
session from the comment. First is, when is MRI preferred over the CT scan?
Excuse me.
When, sorry, when you prefer to use the MRI for diagnosis instead of the CT scan?
I don't. I usually just send them to CT scan because it's a bony.
Oh, okay.
I want to resect the bone, and I am interested in the disease within the bone, so the extent of the bone, and not so much in the soft tissues.
Okay, and the next question, do tissue regeneration therapy is needed, especially for those MRONJ patients who are in stage 3?
So you want, if you can do a soft tissue regeneration for them.
Yeah, uh, do tissue regeneration therapy is needed, especially for those MRONJ patients who are in the stage 3?
I, I, well, you need to remove the bone underneath it, and then you just mobilize the local tissues around it. I don't transplant any soft tissue from anywhere, or you cannot. So if you have an staged, if I understand correctly the question, if you have an exposed bone, would you do a tissue regeneration over that? I think I don't think that's possible, because if you have a necrotic bone and if you put something healthy over necrotic bone, it's not going to stick. It's not going to heal the bone, underneath. The thing is, if I understand correctly, is that underneath you have a bone that is necrotic, and if you want to put anything that's healthy underneath it, so basically your basis, your foundation is wobbly and it's necrotic, so nothing healthy on that is gonna stick. You need to remove the dead bone, and after that you can put anything that's healthy over the healthy bone. But as long as you have something that is dying underneath, nothing's gonna heal over that one.
Okay,
So
thank you. Yeah.
so if you have a root that is exposed due to bisphosphonates necrosis and put soft tissue over it, I don't think, it's just gonna stick. You're just gonna form a fistula, and it's just something's gonna happen in about 3 to 4 months. So you need to remove the bone. You need to remove the cause of this.
Okay, yeah. Thank you very much for the explanation. Due to the gap for the next lecture is very short, I'm sorry I need to close the question and answer session. Thank you very much, Dr. Thomas Binder, for sparing your time to share your knowledge to us. We appreciate also you can being here, and to all the participants, thank you for sparing your time. So thanks again for joining us today, and we will see you next time.
Okay. Thank you very much for invitation. Bye bye.
Bye bye.